Let's talk about the differences between the scoring and treatment of pediatric respiratory events versus adult respiratory treatment and scoring. This is information that a lot of it we've covered, so this should be a review. The equipment and sensors we use for respiratory events include an oronasal airflow thermocoupler, which is fancy words for thermistor, which is used for apneas. The key prefix here is therm, measures the airflow with the temperature, therm changes. Nasal pressure transducers, or pressure transducers for airflow, PTAF, use a cannula to measure the pressure, and they measure hypopneas. Respiratory effort belts are used to tell if a patient is trying to breathe or not, and that's how we distinguish central versus obstructive events. There are alternate ways to score events if there's a temporary cessation of data signal. For apneas, you can use the pressure transducer, the end tidal airflow signal from the capnograph if you're using one, or a special view from the effort belts. The summed calibrated inductance plethysmography means when the belts are on correctly, they can detect airflow signal loss. I'll discuss that in just a second. Snore microphones or snore sensors not only confirm obstruction with recording the snores, it records the amplitude of snores, how loud or quiet they are. Carbon dioxide retention or alveolar hypertension or hyperventilation, which is the same as just regular hypoventilation, is another potential issue for pediatrics. So capnography is used and can be acquired via end-tidal CO2 or transcutaneous CO2. As well as with all respiratory events, you want to know if there is an oxygen desaturation, and for those we track oxygen with pulse oximetry. Okay, let's review some effort terminology. The top figure, represents normal unobstructed breathing. The belts are deflecting up and down at the same time. When they breathe in, the belts go out and the in together at the same time. So you're seeing this, and they're happening at the same time. The belts are deflecting up and down at the same time, meaning they are synchronous and in phase. In phase means the signals go up and down together at the same time. Synchronous means they occur at the same time. The second graph shows a slight obstruction because the belts are no longer in phase or synchronous. They occur slightly off. The last one is synchronous, but they are out of phase. They are going in opposite directions. So, summing, which is adding. When adding the positive or negative deflections and amplitude of the two belts, it demonstrates how much airflow should be occurring. So, for example, let's give these things figures. Let's say that's 0 and that's 0. Above here is positive. Below is negative. Above here is positive. Below here is negative. So let's say when the patient is paradoxing, this belt is up at +4. This belt is down -4. When you add that together, you get 4 plus -4 is 0. So there's no airflow. That's what that little line is there. Check these out. If this was 4 and this is 4 because they're both up at the same time, that's 8. That would be, a full breath. Here there is a shift and they kind of get enough air in to have just a little bit. So this would kind of be like, let's see, this could be like -2 and +2. which is still 0, but maybe this is up a little bit more like 4, so it could be a +2 or so. So that's not nearly an 8 like it should be. That's how these belts are working. And I'm putting arbitrary numbers on them just to show you how that kind of thing works. They use the positive and negative voltage from these, and you can sum those. But in order for this to work, those belts have to be snug, but not too tight, and they have to be perfectly placed. And when patients move around, they're going to get loose, and they're not going to be placed very perfectly. So this is not a very accurate or precise way of measuring airflow. There's a difference in pediatric scoring and infant scoring. Children between the ages of 13 to 18 qualify for adult or pediatric scoring, but it's ultimately up to the physician as to how to report the studies. For infants through 12 years old, pediatric scoring is required. To score an apnea, a few things must be present. First, the thermistor or PAP flow signal must show a decrease in amplitude of at least 90% from how tall the breaths were before the event started. The duration of 90% or greater drop in signal amplitude must last at least 10 seconds. A lot of labs won't score these apneas unless it's a dead flat line, but they're all different. To score an event as obstructive, it must be associated for at least 2 breaths, and respiratory effort must be present the whole time. They have to be trying to breathe, and you have to see that trying or effort in the belts. For the duration, it's easier to score apneas for pediatrics because they almost certainly will breathe several times in 10 seconds. So 2 breaths opens the door for pretty short apnea scoring. Remember that obstructive apneas do not require a desaturation or arousal. Central apneas are scored a little differently. There still must be the 90% or greater signal amplitude loss, but the effort belts must also lose their effort. You want 3 lines, 4 if you include the nasal pressure transducer. The duration is different than obstructive. You can either have a central apnea by itself with no desaturation or arousal that lasts at least 20 seconds, or you can have a central apnea that lasts 2 breaths and is associated with an arousal or a 3% or greater desaturation, kind of like a hypopnea. Infants, on the other hand, have the added stipulation of if the heart rate reduces to less than 50 beats per minute for at least 5 seconds, or less than 60 beats per minute for 15 seconds. This is a decent example of back-to-back obstructive apneas. Notice there is effort in the belts, but no airflow. And that's in the therm and the nasal pressure. These are accompanied by arousals, which we can't really see, but we can see the increase in chin tone, and looks like something is getting darker right there, and there are desaturations also. Here's another one. Right there, arousal, increased chin tone, eyes move a little bit, desaturation. The important thing here is that effort. They're trying to breathe, but nothing's coming out. Central apneas require 2 missed breaths with an arousal or desaturation, or it has to be 20 seconds long. Let's see, these look longer than well, they have desaturations and they're shorter than, looks like they're under 20 seconds. So these are still centrals. And we also have the capnograph. That's what these values here are. Normal capnography is like 35 to 40 to 45. So if you see those kinds of numbers with the airflow signal, that's probably capnography. There are also mixed apneas. That's when part of the event is central in nature, meaning no effort, and part obstructive in nature. And it doesn't matter if it's 50-50% duration or which comes first. Hypopneas are events where the airflow signal drops at least 30% for a duration of at least 2 breaths and is associated with either a 3% duration or an arousal. Hypopneas are scored with nasal pressure transducers for diagnostic testing and with the PAP flow during a titration. The AASM allows alternate hypopnea sensors, but you really need to use the nasal pressure transducer. I don't know how much you've talked about Medicare and Medicaid scoring rules in your other classes, but the manual also permits the scoring of hypopneas requiring at least a 4% desaturation, arousals not included. In this case, you have in the case that you have a Medicaid or Medicare patient, you need to score hypopneas with a 30% signal drop for at least 2 breaths and a 4% desaturation. Arousals don't matter. 3% is not good enough. Otherwise, any other insurance, you're free to score hypopneas with a desaturation of 3% or just an arousal. So the manual did not used to have that 4% rule. That's strictly because Medicare has mandated it for their patients. Do you know what that means? It means that although the AASM has sleep expert whose job it is to figure out the best ways to tell if someone has sleep apnea and they actually give the rules and make the rules for treatment, Medicare decides that that's not good enough and makes their own rules, an insurance company. So because Medicare is such a huge entity and federally supported and has the influence of that sweet, sweet cash, the AASM adds the Medicare rule into the manual. Scoring hypopneas as central or obstructive is optional, but that seems like a horrible idea for me personally. You need to score them as central or obstructive hypopneas, unless your lab tells you not to. Hypopneas are considered obstructive if there is evidence of any of the following: snoring, increased inspiratory flattening of the nasal pressure or PAP flow signal compared to normal breathing, meaning things like flow limitation, or there's an associated thoraco-abdominal paradox that occurs during the event, but not during pre-event breathing. So all that means you're looking for snoring, flow limitation, and paradoxical effort. I have a slide after the next one that will show flow limitations, so you'll know more about that. We score hypopneas as central if there is no snoring, no flattening of the airflow signal, wherever it comes from, and no paradoxing effort. One thing to think about when scoring these events is what's going on when they're happening. Sometimes patients on oxygen may have hypopneas, but no desaturations. Supplemental oxygen may blunt desaturation. Supplemental oxygen is when you've got someone with a cannula and you're actually giving them oxygen. There are currently no scoring guidelines for when a patient is on supplementary oxygen and no desaturation is noted. If the diagnostic study is performed while someone is on oxygen, it needs to be mentioned in the notes of the study. This means that a person on oxygen might be having hypopneas, but because you've got them on oxygen, they're not showing a desaturation because you're pumping them full of that stuff. So they might just be having arousals. Mixed apneas have the same rules as obstructive apneas, no arousal or desaturation required. However, there must be at least 2 missed breaths as well with as a central component and obstructive component in the effort. So here you can see flat line in the nasal, the therm, and then here you've got flat line, then effort, and where that effort happens, there's still no breath. Mixed apnea. Periodic breathing can be scored like hypoventilation, either over a certain duration or the whole study. The manual says periodic breathing is when there are at least 3 episodes of central apneas, no effort or airflow, which lasts longer than 3 seconds and are separated by at least 20 seconds of normal breathing. Central apneas that occur within a run of periodic breathing should be scored as individual apneas as well, as they are individual components of periodic breathing. Scoring RERAs is optional for pediatrics, but it may be something a lab you work for does score. RERAs, or respiratory effort-related arousals, are when there are at least two breaths that are accompanied with snoring, increased respiratory effort, flow limitation, which is flattening of the inspiratory portion of the nasal flow signal, or an elevation in the end-tidal CO2 compared to normal breathing. Truly, RERAs require a building up of effort. The belt should look like a staircase going up. Monitoring hypoventilation in children is recommended during the diagnostic study and optional during a PAP titration study. Depending on your lab's specific policies, hypoventilation can be scored as a duration, like 5 minutes over 50 millimeter mercury, or in the case of the AASM scoring manual, 20% of the whole sleep study would have to be over 50 millimeters mercury. Neuromuscular weakness and other congenital disorders are some causes of hypoventilation. So how do you know if a patient needs treatment? The severity of the symptoms, reviewing the physical examination for OSA-producing features, as well as the sleep study results are all pieces of the greater diagnosis. A combination of treatments may be used if the symptoms are really bad, or if one is not enough. The provider may decide not to treat. If the provider decides not to treat, the patient still needs follow-ups, and even when you treat them, they still need them. Pediatric patients tend not to have total obstructions, more upper airway resistance syndrome, which can still have severe implications on the quality of sleep. Upper airway resistance syndrome, or UARS, is it's like just under obstruction, just slight paradoxing or out of phase respiratory effort, as well as snoring. It's been shown to affect the sleep quality. Tonsillectomy and adenoidectomy are basically the gold standard of pediatric sleep apnea for therapy. It's typically chosen instead of CPAP because of the low compliance rates. There's evidence that adenotonsillectomies are not a cure and obstruction will continue. Adenoids are also known to have regenerative capabilities, meaning they can grow back. Patients who have very small tonsils, or patients without tonsils, or patients who have a bleeding disorder, they're not candidates for TNA, what we like to call a tonsillectomy and adenoidectomy, TNA. You may hear the word contraindication. That means reasons not to do something. Small tonsils is a contraindication for tonsillectomy. Contra meaning contrary or against, and indication meaning reason to do something. As do all surgical operations, this one has complications. They may include hemorrhage, which is uncontrolled breathing, anesthetic complications, since anesthetic can cause depressed respiratory functions or make a patient not breathe as much. There could be pain, poor oral intake, meaning for food and drink, death, velopharyngeal incompetence, postoperative worsening of sleep apnea. After surgery, the patient may experience edema, or collection of fluid in certain areas, mainly in the throat, which can cause obstruction. Velopharyngeal dysfunction is when the soft palate and throat muscles don't close off the nose or mouth while swallowing or talking. There's an estimated 13 to 29% residual sleep apnea post-operation. Again, OSA is a combination of things, not just the tonsils. Despite all this information, know that a TNA, a tonsil and adenoidectomy, are the first-line treatment for sleep apnea in pediatrics. Just know that for the exam. Here are even more surgical risk factors when it comes to respiratory complications or who is at risk for breathing problems, most likely central apnea activity. This demographic includes patients younger than 3 years old, those with severe OSA, because it's highly unlikely the patient will be able to breathe sufficiently during the procedure. Failure to thrive, the patient may not be strong enough to survive such a procedure. Cardiac complications, particularly right ventricular hypertrophy. Obesity, which can induce hypoventilation. Prematurity, premature babies don't have a fully developed respiratory system. Craniofacial anomalies, which may be the true source of the OSA. and neuromuscular disorders which can affect the diaphragm and other respiratory effort muscles. When considering an adenotonsillectomy or related procedure, there are some things that can be done to reduce the risk of adverse reactions, either to the surgery or most likely the anesthesia. First, the providers should specialize in pediatric airway surgery, especially because they would be more accustomed to the different airway sizes, since children are always growing, unlike adults. If something goes wrong, a pediatric ICU should be there to intervene. Some providers will give the patient a sedative prior to going into surgery. This would be like a benzodiazepine to relax them so they're not freaking out before getting needles and the other scary things happen. Also, you obviously don't need to send the patient home right after you rip their throat out. There should be comprehensive post-operative monitoring to ensure the effects of the anesthesia and surgery have no ill effects on the patient's health. So why doesn't OSA improve immediately once the tonsils are gone? Well, remember there's increased edema and considerable inflammation from the incisions. Those can cause residual sleep apnea. A repeat sleep study should be performed approximately 3 months post-op to qualify the success of the procedure. You don't want to do it before that because it could be erroneous information. Patients who may be considered for PAP therapy are those who do not qualify for surgical intervention, as well as those whose surgical intervention fails. There are many reasons surgery may not be successful, mainly that tonsils and adenoids alone are rarely the only obstructive features about those patients. PAP therapy is only available, PAP therapy is only approved for children who weigh at least 66 pounds. You really need to pay attention to something like that when you're titrating children. Although it's not approved, it may still be needed. Because there are always growing, frequent mask fittings and retitrations may be necessary. When you use bilevel, there is a mechanism that tells the machine when you're ready to breathe in, and that's called triggering. Triggering algorithms are not suited for the lower flow rate and faster respiratory rate in children, so it can be difficult to use bilevel. There is also a risk of aspiration with the use of full face masks in children. There are very few mask choices available, mostly because it's so hard to get the FDA approval for children's devices and supplies. Pneumothorax is when air escapes from the lungs and begins to fill the cavity between the lungs and the lung wall, the interpleural space, taking away space for the lungs to expand and get enough air in. Barotrauma, baro meaning pressure and trauma meaning damage, is physical damage to the body's tissues caused by a difference in pressure between an airspace inside or beside the body and the surrounding gas or liquid. This can cause excess pressure on the eyes, ears, or even the brain. You may notice that if you turn the pressure up too high on just about anyone, they will begin to have central hypopneas or apneas. This is from the Herring-Brewer reflex, which is a reflex triggered to prevent overinflation of the lungs. There are pulmonary stretch receptors in the smooth muscles of the airways, and they respond to excessive stretching of the lung during large inspirations. Once those stretch receptors are activated, they send action potentials through the large myelinated fibers of the paired vagus nerves to the anoustic center of the pons, inhibiting or stopping the inspiratory neurons from allowing more lung expansion. This stops inspiration, requiring equalization of the pressures with exhalation. That's a lot of words. Hypoplasia means underdeveloped, which mid-face hypoplasia means the middle of the face is underdeveloped. Remember, midline deformities are pretty common. This includes the bones in the mid-facial area like the maxilla, the nasal bone, the zygomatic process, and the cheekbone. These are all malleable during childhood, and they continue to grow until about 12 years old. When putting kids on CPAP, start before they even come to the sleep lab for the initial titration. They should start at home with an assortment of mask types to find out which one stays on the best or which is the most comfortable. In the end, for adults, at least it's the mask that is the most comfortable, and that's usually the ones that works best, especially if the patient likes to wear it. The parents need to be educated on the process and what to watch out for when the patient is sleeping. They should know about excessive leaks and monitor that their child is keeping it on all night. Let's be honest, most kids take the mask off during the night and sleep throughout the leak sound. The parents should start putting the CPAP on as just another part of bedtime routine, just like turning out the light. The more routine the process is, the more likely the patient will adhere to it. Sometimes there are features about the patient that may be worth correcting if there appears to be a central component to the obstruction. And by central component of the obstruction, I mean a main characteristic. Genioglossus advancement is a surgical procedure where a small portion of the lower jaw, which attaches to the tongue, is stitched forward to increase the airway size. This is usually to correct a deformity. Advancement mandibular osteotomy is the surgical cutting of the jawbone to advance it forward off of the airway. And there's also the UPPP, the UPPP, or the uvulopalato-pharyngeoplasty. That's where they take out the tonsils, the uvula, extra tissue of the palatopharyngeus, as well as the palatoglossus muscles. On top of that, they take out about 1 centimeter of the soft palate where the uvula was. This is an extreme and radical treatment, and I've had adult patients that have gone through that just to need CPAP. We've talked, well, not just to get CPAP. I mean, they went through all that hoping it would work, and it didn't, and now they're just at CPAP. We've talked about childhood obesity and its prevalence. Sometimes when it's not a specific genetic disorder, if the child has a good diet and gets good exercise, weight can be controlled. Oxygen may be used until there's a better treatment. However, oxygen and gas exchange for OSA is not the problem. There's an obstruction, and it doesn't matter how much O2 you pump into someone. If their throat closes, ain't nothing getting in or out of there. Occasionally, patients will find success in medications like glucocorticosteroids and nasal steroid sprays to assist in airway patency. Patency is keeping that thing open. Glucocorticosteroids shrink adenoidal tissue involved in carbohydrate metabolism, and also in fat and protein metabolism and many other activities like alteration of connective tissue response to injury and inhibition of inflammatory and allergic reactions. Kids with sleep apnea also appear to have high prevalence for allergies. So avoiding cigarettes, smoke, chemical fumes, and environmental allergies, as well as supplementing with an antihistamine, may aid in keeping the airway clear from obstructive mucus. Gastroesophageal reflux disorder can also cause inflammation with edema in the throat. It can cause edema of the pharyngeal and laryngeal mucosal wall, as well as tonsillar swelling. A proton pump inhibitor like Prilosec or Nexium can be used to inhibit GERD, gastroesophageal reflux disorder, and its sleep apnea effects. Occasionally, the maxilla and hard palate can be altered with oral or orthodontic appliances, which can reshape the skeletal growth. Rapid maxillary expansion, seen in the figure here, attempts to use pressure to push the jawbones outward to open the airway. At least one surgical follow-up should be scheduled to ensure the incision site is healing well and there are no residual problems. Follow-up should continue if the patient's situation does not improve, and typically the minimum diagnostic criteria without comorbidities is 20 per hour for the respiratory disturbance index. Follow-ups are routine for those who continue to be obese and those with neuromuscular disorders, which virtually are always terminal conditions. So that'll be it for this one. We've got one more to go.